Hello and welcome to the Discover Series 4, the fourth in the series of online education sessions brought to you by Salts Healthcare. In this first episode, we will hear from Melanie Baker. Melanie is a senior specialist dietitian for the nutrition support team in Leicester. Melanie and her team manage a caseload of complex nutrition support and intestinal failure patients, including patients receiving home parenteral nutrition. I think the subject of diet for many individuals living with a stoma always gives rise to concern. As stoma care nurses, our advice is seen as invaluable to our patients, so it's important that we work collaboratively with our dietetic colleagues to ensure that the information that we're all providing is universal, so as not to cause confusion or ambiguity to our patients. In this opening episode, Melanie explores why dietary changes are sometimes necessary for patients following stoma formation, as well as looking at some of the physiological changes to the gastrointestinal tract that can occur sometimes after surgery and the implications that that can have. She helps us to try and understand how the body absorbs certain electrolytes and the impact that that can have when the GI tract is compromised.
Thank you to Salts Healthcare for asking me to present to you today. In this session, I'm going to critically review the dietary recommendations that are made for patients living with a stoma. So let's first consider the potential reasons why dietary changes are recommended. Management of malnutrition, particularly around the time of surgery. We also need to consider the physiological changes to the GI tract and implications for digestion and absorption. Patients are often recommended to make dietary changes to reduce the risk of stoma-related complications. So, for example, to manage a high volume output or to manage complications such as intermittent bowel obstruction. And also we see that dietary recommendations are made in terms of trying to alter the function of the stoma. We must also remember that patients living with stomas may also have an underlying clinical condition, for example, diabetes, or they may choose to follow a certain diet regime, such as being a vegan or vegetarian. And it's often that the dietary advice given can be conflicting, and it's important that we give individual advice so we don't increase levels of sort of concern or uncertainty. So let's first go on and talk about malnutrition then. There's a wealth of evidence now to say that malnutrition is common in colorectal surgical patients, both preoperatively and also at the time of surgery and after surgery. Whether a stoma per se actually increases the risk of malnutrition is not really fully understood. Patients before having a stoma surgery may be at risk of malnutrition because of their underlying disease. So, for example, if they have inflammatory bowel disease that's been difficult to manage. During surgery or during that hospital stay, we also see metabolic changes that occur, and it can affect how nutrients are metabolised, and it can also cause problems like a reduction in lean body mass. During hospital stays, we also see problems with things like enforced periods of nil by mouth, or patients that don't have adequate nutritional intakes during their hospital stay. And after surgery, certain groups of patients are also at high risk of malnutrition. So, for example, patients that may have had stomas because of colorectal cancer that may be going on to have other treatments such as chemotherapy. What's important to remember that an undernourished patient is often quite apathetic and they can have little desire to eat or engage in therapeutic activities. And that's really important. If we think about our patients on hospital wards, we're trying to get them engaging with things like physiotherapy. As colorectal nurse specialists, you're also trying to give training and education. And we often find that if patients have had prolonged periods where they've been starved or had a lack of nutrition, it can really affect even simple things like having to read a newspaper or feel that they can concentrate. So it's important that we make sure that we are giving adequate nutrition. Treatment of malnutrition around this time of surgery is really key, and that starts with early identification. So most hospitals will use some form of nutritional screening tool, and these can also be used to screen patients in the community. The one that's most commonly used is the MUST tool, and I've put the website there for how you can access information about that from the BAPN site. You should also have guidance locally about when you should be able to refer for more specialist advice, so when you can refer a patient to a dietitian. The key thing is we need to avoid introducing delays in providing post-op nutrition. So as colorectal nurse specialists working on the wards, it's really important that you challenge nil by mouth status, or you challenge a slow reintroduction to diet. I've been working in the NHS for quite a long time, and I can remember going back to a time when the surgeons used to often do things like say patients can have 30 mils of fluid an hour, and that would slowly increase to 60 to 90 to free fluids. And obviously that is just adding delays in getting back to giving adequate nutrition. Thankfully, practice has changed, and we do now see things like enhanced recovery programs after surgery that don't just focus on nutrition, and nutrition is just one element of that, but it is about ensuring that we are not adding delays in terms of getting patients back onto an adequate dietary intake. We do need to consider, though, that there are, for some patients during that immediate post-operative phase, it's quite difficult and then they're not able to return to a normal diet. And in this situation, we must consider artificial nutrition support. You can give supplementary enteral feeding for somebody that's not able to tolerate an adequate amount of nutrition via a diet. So short-term nasogastric feeding can be recommended. And in the area of practice that I work within, nutritional support teams, we manage patients that require intravenous nutrition, so parenteral nutrition. And I've listed some of the indications for short-term use of parenteral nutrition here. So we may see patients that have issues with a post-operative ileus, they may have a bowel obstruction or some sort of perforation or complication after surgery, which is resulting in things like intra-abdominal sepsis. We also would see patients get referred to us for parenteral nutrition that have fistulas. Historically, the practice for fistula management was actually to put patients nil by mouth and give parenteral nutrition. That has changed somewhat now, and it is important to consider the position of the fistula. Also, again, is it related to a collection or intra-abdominal sepsis? And we will, where possible, try and make sure that we are giving some form of oral intake to patients with fistulas. But it may be that we have problems with a very high output or with losses of fluid and electrolytes, or situations where, for example, wound care is becoming quite difficult to manage, where we may restrict someone's oral intake to see if that reduces the losses and makes things more manageable. And we would also give parenteral nutrition to those individuals that have a very short bowel, so a short proximal length of bowel to stoma, normally of less than sort of 200 centimetres. It's not all about bowel length, though. It might also be that they've got an issue with the function of their remaining bowel, and if they're having big issues with malabsorption, we would give parenteral nutrition. Let's go on then and talk about the physiological changes that occur in the GI tract and its implications. First of all, it's really important just to remind ourselves about normal digestion and absorption. So I've listed that here. So in the stomach, you start digestion, although actually you start digestion when you produce saliva in the mouth. But the role of the stomach really is to deliver the food at a controlled rate into the small bowel. The small bowel is made up of two main parts, the first being the duodenum, and this produces alkaline secreting glands to neutralise the acid content of the stomach. And it also produces those pancreatic enzymes and bile, which are released on the presence of food to aid digestion. The second part of the small bowel is the jejunum and ileum, and the length is very variable. It's often correlated to height, and the role of the jejunum and the ileum is the absorption of macronutrients, so your carbohydrates, your proteins and your fats, and also your micronutrients. The key thing to note here is that you get a 3 to 5-fold dilution of your food by digestive secretions. So there is a huge amount of fluid that is travelling through the small bowel daily. The other key thing to remember is that at the end of the ileum is the ileocecal valve, and this slows down digestion. So it slows down the passage of nutrients through the small bowel. And the body is very clever. So if the colon finds that nutrients are getting to the colon too quickly, then there are mechanisms in place to actually slow down the passage of travel through the small bowel further up. So that's really important. Okay, going on again to look at nutrient absorption then. This is a useful table, which I'm not going to go into in huge detail, but it does show you the sites of absorptions for your micronutrients, so your vitamins and minerals, and also for other things that are quite key, particularly in terms of things like electrolyte absorption and water. So with adequate pancreatic function, most carbohydrates, proteins and fats are digested and absorbed in the upper 200 centimetres of small bowel. Your water-soluble vitamins are actively absorbed in the upper GI tract, and that's with the exception of vitamin B12. So that's selectively absorbed in the terminal ileum. So if you have a patient that has a small bowel stoma where they've had the terminal ileum removed, they are at risk of vitamin B12 deficiency. And in that case, they would require injections rather than just trying to increase the amount that they're taking in by mouth. Fat-soluble vitamins are dissolved and absorbed throughout the small bowel. Okay, but the key thing is, and what we need to remember with stomas, particularly small bowel stomas, is that the transit time will affect absorption. And what we're trying to do, particularly in those that have a high output, high volume output, is we're trying to increase the time, the contact time between the passage of nutrients through the bowel and the chance of it being reabsorbed. So that's why when you're trying to manage someone with a high output, we do things like give medication like loperamide to slow down the transit, so the stuff's got more time to get reabsorbed. Okay, the final bit we need to consider in terms of GI tract function is what the large bowel does, what the colon does. So that's really key in the reabsorption of water, sodium and magnesium. And the other thing that's really important is your microbiome, and considering the role of dietary fibre and what happens to that in the large bowel in terms of how it is metabolised by bacteria. And we see fermentation of that dietary fibre to short-chain fatty acids. This is a really important function of dietary fibre, and it's thought to help with the management of diarrhoea. The downside, though, of fermentation is that it can cause flatulence. Okay, going on then to talk in a bit more detail about fluid secretion and absorption. We need to remember that a huge amount of fluid travels through the small bowel on a daily basis. So you produce fluid from saliva, gastric acid, from your biliary and your pancreatic enzyme secretions. So in the first part of that small bowel, you can have sort of 7 to 9 litres of fluid travelling through it every day. What happens then in the distal part of the small bowel is that is then reabsorbed, so that only about 1 to 2 litres of fluid actually travel past the ileocecal valve into the colon. And then further fluid is reabsorbed, so that normally if you have a normal intact GI tract, very little fluid is actually lost in the body daily. You can see there then, can't you, that if you've got a stoma that's high up, so you have a stoma that's formed in your jejunum, you would expect that to be producing a lot of fluid. So actually, if you've got someone that's saying you can't send this patient home until their output's down to sort of less than 2 litres a day, that's going to be really difficult to manage. And actually what's more important is if you can actually replace the losses that the patient is actually experiencing. Okay. We also must remember that it's not just about fluid, but it's also about electrolytes. You're probably all familiar with the situation where a patient that's living with a stoma comes back into hospital because they are dehydrated or they've gone into acute renal failure. And often what can happen is they turn up on a medical assessment unit, they're dehydrated, they get given some intravenous fluid, told to drink more and then sent home. And actually these patients can often have repeated readmissions and keep bouncing back into hospital. And that's because they become salt depleted. So it's not just about replacing the fluid, but it's about replacing the electrolytes that they're losing. This information from NICE is really useful because it tells you the electrolyte content of different types of secretions. And as I've said, it's really important that you get adequate replacement of fluids and electrolytes. The other thing to remember is that often a depletion of one electrolyte will compound other electrolyte deficiencies. So again, for example, if you've got someone that has got a high stoma volume and they are losing sodium that's not being replaced and they're becoming sodium depleted, the body's very clever, the kidneys are clever, they will try and conserve the sodium. So what you will find is the kidneys will hold on to sodium, but because of the sodium-potassium pump, they will hold on to the sodium and you will pee out more potassium. So then those patients become potassium depleted. And actually, often the management of this is not to give them more potassium, it is to get on top of their sodium depletion, so then their potassium levels will be maintained. Okay, just to go through sodium absorption then, and I will cover this in more detail when we go on to talk about high output stomas, but sodium absorption occurs mainly in the colon. So in the small bowel, we have to look at how we can help the small bowel reabsorb sodium if it needs to do that in the absence of a colon. So if you go back to sort of your chemistry lessons, if you think about you've got solutions where you've got a concentrated solution and a less concentrated solution, and often things move from one area to the next through a membrane, this is what you see happening here. So when you, for example, drink a cup of tea that's not got any sodium in it, it will go into the bowel. And what will happen is you've then got a very low sodium concentration in the bowel compared to a much higher sodium concentration in the blood, in the plasma. And what will happen then is the sodium will move from the plasma into the bowel. And as the sodium moves, it takes water with it. And that's to try and maintain this sodium concentration in the bowel that is really quite high, so sort of 90 to 140 millimoles per litre. To try and get that sodium actually from the bowel back into the plasma to be reabsorbed in the jejunum, that can only occur against a small concentration gradient and requires glucose. So if you think about why oral rehydration solutions are used, one, it's because they contain adequate amounts of sodium, so more than 90 millimoles per litre, and they also have some glucose to help that absorption. You have to remember in contrast though that the ileum is very clever and it can absorb sodium and it will become more, and that will improve over time. So you will find that adaptation occurs. And we often talk about new stomas having a phase of adaptation that can occur in the first sort of 6 to 8 weeks. And you'll see on this slide here that the sodium concentration, so the sodium losses from a stoma will change because of that adaptation. So whereas with a newly formed ileostomy, the sodium concentration is about 100 to 140 millimoles per litre, in one that has actually adapted over time, the losses can reduce down to sort of 50 to 100 millimoles per litre. And the other thing we find is that generally less fluid comes out, the stoma volume becomes less and the consistency increases and it becomes thicker. Okay, so to summarise that section then, we do see in ileostomy patients that they are at high risk of nutrient deficiencies, particularly vitamin B12 if they don't have the terminal ileum, but also other vitamins or minerals such as iron. They are at risk of being salt depleted, so sodium depleted, and having other deficiencies of things like magnesium. They require higher intakes of fluid, but also of salt. And if someone has a short bowel, so less than 200 centimetres of small bowel to stoma, or the remaining small bowel, whatever its length is, has poor absorption capacity, then they are likely to require some form of intravenous support, whether that be nutrition or it may be electrolytes and fluid management. Okay, let's go on then to talk about the other dietary changes that are often seen and why we do this. So we may be giving advice on changing the composition of a diet to influence complications. So this will only be in that subgroup of patients that are more prone to problems. So for example, if you have somebody that has adhesions and more at risk of adhesion or obstruction, or if you have someone that's got a high output stoma. But actually, generally, in anyone that's got a stoma, or as anyone that's living with a stoma, they may alter their diet to try and help with some of the effects that diet has on their stoma function. So that might be in terms of things like consistency, or it might be in other side effects. So, for example, odour or the production of wind. Okay, so the dietary modifications that are often suggested are a fibre restriction, I have put in brackets there or increase because I am conscious that I'm really talking about small bowel stomas a lot here. And actually, in patients that have a colostomy, for example, the advice often is to increase fibre and increase fluid to help with stoma function. But going back to small bowel stomas, you often see that there is advice to avoid certain fruits, nuts, vegetables, and we also may promote certain foods. So it's often quite common to promote foods that have gelatine in, so things like marshmallows, jelly beans. I know in paediatrics often pectins encouraged, so things like applesauce. We often recommend starchy low fibre carbohydrates, so things like mashed potato, boiled rice, pasta, rice cakes to try and help thicken up output. We give advice, as I've said, about fluid in terms of the type and the amount taken and the amount of salt that someone should have. And we sometimes suggest dietary modifications in terms of just things like general changes to meal pattern. So it may be that people choose to eat their larger meal early on in the day, so have their larger meal at lunchtime rather than in the evening. They may choose to stop eating a couple of hours before going to bed, and this is to try and reduce the function of the stoma overnight. With all these recommendations, though, we need to go back to thinking where they actually come from. We obviously are advised to try and follow evidence-based practice, but really the evidence is still quite poor in this group. Our evidence really comes from expert opinion, case reports, anecdotal advice. I suppose I've got a lot of my experience from just talking to lots of individuals over quite a few number of years. There are very few controlled studies in this group. So we haven't got large studies where we've taken a large population of ileostomy or stoma patients and we've given them one diet and we've assessed the effect of it, and then we've put them on a different diet and assessed the effect of it. We do have a bit of evidence from something called an ileostomy model. So this is sometimes used to assess the effect of, say, for example, one nutrient. And this is where you would take a small group of subjects that have got established stomas and you would give them a test diet, so test diet A. You'd then give them a washout period and then you'd give them another test diet. So an example of where this might have been used is when they were wanting to look at the effect of a soluble fibre on blood cholesterol levels. But that does give us some advice about how different diets can actually affect stoma function. Okay, so as you can see, a lot of the recommendations are based around fibre intake. So I thought it would be useful just to talk a bit about what dietary fibre is. This is actually quite complex. Essentially, dietary fibre are carbohydrates that escape digestion and absorption in the upper GI tract. But you need to bear in mind it's a very heterogeneous group of substances and they all have different actions. So it can affect how soluble something is, how bulk forming it is. I've obviously already mentioned that the key part and the key function of fibre is what it does in the large bowel in terms of fermentation. You'll also come across different terminologies for different types of dietary fibre. So you'll see things like non-starch polysaccharides. Often if you pick up a cereal packet of sort of a whole grain cereal, it will say it's got a source of non-starch polysaccharides. There is also dietary fibre, something called resistant starch. That's found in, for example, banana. So a banana that's green has a lot of starch in it that you can't digest, and as that banana ripens the starch goes to sugar, so it gets sweeter. So resistant starch is found in plantains, green banana. It's also found in certain foods which we wouldn't normally consider to be high fibre. So for example, a potato that's cooked but then cooled. When it's cooled it then has resistant starch in it. Sometimes you'll see dietary recommendations that talk about soluble or insoluble fibre. So soluble fibre is often that sort of gel forming, and sources of soluble fibre are things like carrots, oats, barley, sweet potato. Whereas insoluble fibre is more your whole grain cereals, some of your vegetables like things like kale that have quite a tough stalk or husk. It's often said that soluble fibre is easier to tolerate for those with a stoma, But I think, again, it can be quite complicated, and lots of foods actually have an amount of soluble fibre and insoluble fibre in them. Daily recommendations for fibre in the general population are to consume about 25 to 35 grams a day, and a high fibre food can be classified as one that contains more than 6 grams per 100 grams. But again, just looking at the amount of fibre in something is sometimes too simplistic. And I would never recommend that someone actually tries to pick a label up and just select a food just on the fibre content. We have to also remember that fibre content is affected by things like soaking, cooking, that sort of thing. Okay, so what we need to do is ask ourselves when a fibre restriction is actually needed. As I said, I've done this job for quite a long time, and years ago we used to basically give one diet sheet out, and the advice that we were giving someone to an who'd just had stoma surgery seemed to be the same advice we were giving for them to still be following when they're a few years out of having stoma surgery. And we now recognise that that's not correct. You need to give some advice for that immediate post-operative phase, but actually after that we need to be trying to reintroduce other foods back into the diet. So immediately post-operatively, and when the bowel's been operated on, it becomes very boggy and it's edematous. And it's also the situation where they are at risk of complications, so things like a post-operative ileus. And it's in this phase that we need to be encouraging people to follow a low-fibre diet. We may also suggest a low-fibre diet for those with a high volume output. And that's really to see if restricting the fibre reduces the volume. And again, that's by slowing down transit time, and that's why we do it. But in those with an established stoma, unless there's a particular reason why they should continue on a low fibre diet, we need to be trying to introduce fibre back into the diet. So one reason where patients might have to be more restrictive is if they are suffering from obstruction, intermittent or subacute. So I've already mentioned adhesions. You may also see, for example, tumours that cause a problem. So we do see ladies with ovarian cancer where they may have obstructing tumours that are causing problems with bowel function. As patients or those living with an established stoma may also vary their diet to try and manage the symptoms, as I've said, of things like odour and wind. But this is really individual, and the key thing is we should be encouraging people to try foods and, where possible, start including more in their diet. Okay, so as I've said, for those that have a newly formed stoma, the advice often is sort of little and often intake, especially if their appetite is poor. They need to take time, chew their food well, and choose nourishing low-fibre options initially. So as I've said before, those sort of low-fibre, starchy foods. If their appetite's poor, we would also recommend high-protein foods. And if they are including foods that have fibre in, particularly things like fruit and vegetables, try and modify them to reduce the fibre content. So that would be things like taking the skins off, avoiding pips, avoiding husks and that sort of thing. And we would advise these people to also avoid foods that increase the risk of blockage. And I've just listed those here. So mushrooms are not broken down at all in the small bowel. So basically they will come out as they go in, minus how they're chewed. And we would also see things like sweet corn that can probably come through completely intact. So they're the sort of foods that we would recommend to avoid. Once the stoma is established, then actually some of these things aren't so much of a problem. So unless you've got problems with narrowing or stenosis, then foods passing undigested into the stoma bag is not particularly dangerous. You can enjoy foods, some foods, but bear in mind that it might cause, for example, a change in colour. So beetroot, for example, may change the stoma output and make it red. Foods may increase odour. But again, if you enjoy eating those foods, then just include them in your diet, but maybe choose the better time to have them. So enjoy those foods maybe if you're not planning to go out later on in the day. And bear in mind as well that other foods can stimulate bowel function. It's not just fibre. So you may have to be careful with things like spices, alcohol, prune juice. Also be careful with things like fruit juice. And again, that's because of the osmotic effect of some fruit juices. So I've included this reference. looking at the date here, you can see that it's really old, but this was a very, very large study that was done where a survey was sent out to people that were members of the Ileostomy Association, and they were asked to rate foods in terms of some of the effect it had on stoma function. So they looked at increasing watery flow, flatulence, pain and odour. And you can see from the list there on the left-hand side, they're quite common foods, sort of beans, cabbage, onions. So for example, with onions there, 39% of people said that it did increase odour. The key message that you need to take away from this slide is, though, that actually an awful lot of people could include those foods in their diet with no issue at all. And this is really important. I think we see a lot of people that actually just want to be given a list of what they should avoid. And this is why we can't just give them a list, because actually what can affect one individual might not affect another individual. And the key thing is about trying to have these foods sort of a trial and error. There are a lot more recent surveys that have been conducted which show similar results to this, but the other thing they show is actually it's quite common for people never to have even tried these foods because they were recommended right early on not to have them. And I think it's our job as dietitians or colorectal nurse specialists to actually try and encourage people to get back into having a balanced diet and including as many different types of foods as possible. Just want to mention food intolerances then. I think the self-reported incidence of food intolerance is increasing in the general population. It's more common for people to say, oh, I can't tolerate gluten, or I seem to have a problem with dairy. There is no evidence that stoma patients have an increased incidence of food intolerance, but I think generally they are just more aware of the effect of what they eat, what they put into their mouth, what effect it actually has on their bowel function. We would always be concerned if someone is cutting out a food group, it can lead to deficiencies. So if someone's chosen not to have dairy products, for example, we've really got to think about alternative sources of calcium or whether they need some form of supplementation to avoid a deficiency. I will mention lactose though. I'm not recommending at all that people try lactose-free diets, but lactose is a sugar that's present in milk and it requires an enzyme, lactase, to digest it. And lactose is is part of the FODMAP group. You may have heard of FODMAP diets. They're often recommended in the treatment of things like irritable bowel syndrome. And it's a group, again, of short-chain carbohydrates that are poorly absorbed in the small intestine. And when they were investigating FODMAPs, they did use that ileostomy model that I mentioned earlier. And they showed that in those ileostomy patients, having a diet that was very high in FODMAPs increased output, caused problems with bloating and gas. And if you Google FODMAP and you look at what's on the high list, you will see, again, it's those foods that sometimes established stoma patients say they are more likely to have a problem with. So things like onions and cabbage. So again, I wouldn't recommend someone following a FODMAP diet, and particularly not doing it again unless they've got specialist sort of advice. But it's just showing that it's those foods that are more likely to cause a problem. Okay, there are foods though that can have a beneficial effect on stoma function. So I've mentioned starchy carbohydrates. The key thing as well is I think you've got to see that if someone actually enjoys a food, rather than eliminating it, try and see how you can modify it. So again, for example, rather than eating a raw apple that's got a skin on it, see if you can include apples in the diet by maybe peeling them and stewing them in an apple crumble or an apple pie. For salad vegetables, for example, pepper, that again's got the skin on it, which is the fibrous part, can you actually maybe roast it or buy roast peppers in jars in the oil where it's been roasted and the skin's been removed, because that will be lower in fibre. We do often get asked about things like smoothies. Again, it really depends on the individual and the amount of fibre that is needing to be restricted. So if you take lots of vegetables and just put it in a smoothie, put it in a liquidizer and take nothing out, you have still got the fibre there. The fibre is still present. But for some other people, they do find smoothies are a good way of getting enough vegetables and fruits into their diet, so they're getting the vitamins and the goodness from that. So again, it's probably a case of trialling them and seeing what effect it has. Okay. I will mention marshmallows because we often get asked about marshmallows or other gelatin-containing food. This is quite interesting because it actually is a randomised crossover trial where they actually tried giving marshmallows. So marshmallows were consumed 3 times daily for 1 week. Then there was a washout period. Then the same diet was followed without the marshmallows. And they actually assessed the effect on stoma function. They looked at output and frequency of bag changes. But I think it's really interesting because actually it shows that the median reduction in output was 75 mils a day. And only 3 subjects out of the 28 that completed the study said that they had a reduction in output of more than 200 mils a day. So again, I think this shows that actually marshmallows might have a place and they might help certain people, but for some people they will try them and it will have no effect at all. So don't recommend marshmallows to everybody, but say, well, try them and see. If they work, continue having them, and if they don't, then we know that they're not going to be beneficial in your case. Okay. As I said before, I have focused this talk mainly on small bowel stomas. I just wanted to mention colostomies though. We don't see high outputs in colostomy patients. In all my years of managing that group, we've only ever seen 2 patients with high output colostomies. One was a chap that actually had C. diff, and as soon as that was treated, the output came down. The second patient had a colostomy, but actually had Crohn's disease and had about 6 previous bowel resections. So he actually had a short bowel to colostomy, and that's why his output was so high. So we don't generally see high volume outputs in a colostomy. The output will still be dependent on things like position of the stoma, presence of disease, oral intake, but we do see that often constipation can be a problem in this group, and you can get issues with things like pancaking, where we have to encourage people to have more fibre in their diet, more fluid in their diet. They may also need to think about having things like fibre gel to actually help with that, the function of that stoma. Okay, so generally in terms of dietary advice, there is no evidence to support a restrictive diet in those with a colostomy. As I've said before about bacterial fermentation, you may find that they suffer more with wind, and they again may want to avoid some of those fruit and vegetables that are more wind producing. A lot of the dietary literature out there will suggest things like avoid swallowing air, which is quite a vague term, but I suppose it's things like maybe avoiding chewing gum, lots of carbonated drinks and that sort of thing. We're probably also all aware that the difficulty is that people often report that they get a lot of conflicting advice on diet. So this was a survey that was conducted last year. It was just under 300 people that were included, and quite a lot of them had had stomas for more than 10 years. A lot of them talked about lack of support generally, so lack of support in making meal choices in hospital. And actually, I think the other thing that's really quite sad is the number of people that didn't see a dietitian or a stoma nurse, and they weren't given that specialist support. So that's a real problem. I've also included here some quotes from other studies that have been done. So there's been qualitative research that's been conducted in this area, again interviewing those that are living with a stoma and finding out their concerns. And we do know that it is a big concern for people in terms of mixed messages. The advice that they're giving is often conflicting. And these stoma-related concerns around diet are persistent and can last for some time. Okay. So the final thing I wanted to talk about was I mentioned those people that might have to make dietary adjustments because of a stoma, but then they also have underlying health conditions. And I think what we need to consider then is what is the most important short-term need. If you've got someone who keeps having intermittent bowel obstruction, then actually you're going to have to restrict their fibre. And that might go against the advice they've had previously, for example, if they're diabetic. So I think you need to think about what is actually needed for that individual person at that time. You may need, in this case, if it's quite complicated and the diet advice is conflicting, you would need to think about getting some specialist advice and see if those patients can get referred to a dietitian. And the key message really is to avoid longer term, sort of very restrictive diets, and you need to also consider the overall nutritional quality of a diet. It's important, for example, if you think about those patients that have stomas because of colorectal cancer, we have to think about things now like risk of secondary cancer. So it's really important that people have a balanced diet that's adequate in micronutrients and all the other things that we would recommend. So in summary then, dietary modifications are very common. It's really important though that the advice we give is consistent, and I would say please go back locally and discuss it with your colleagues, talk to your dietitians, talk to your surgeons and see what advice is actually being given to people and try and make sure that it is consistent. It's always really important to explain why certain foods may be problematic, but also encourage trial and error and try and ensure that people aren't following overly restrictive diets. Where possible, modify a food rather than eliminate it. But do bear in mind that if people are choosing to severely limit a certain food group, so for example fruit and vegetables, then they should be encouraged to take a one-a-day multivitamin supplement, for example, to ensure that they're receiving adequate amounts. Okay, so that finishes this section of the talk. Thank you for listening, and I hope you found that useful. Thank you.
Thanks, Melanie. It's so interesting. I always say to my 12-year-old daughter that the human body is such a clever machine. How it functions, it absorbs and adapts in so many different scenarios. I find it so fascinating. I think Melanie clearly explained why specific dietary modifications are needed to reduce the risk of stoma-related complications, or perhaps are necessary to alter the stoma function to improve the quality of life for our patients. Diet and what individuals can and cannot eat is subjective and can cause many patients a huge amount of anxiety. Consequently, we as stoma care nurses do get posed numerous questions on the topic. With this in mind, we have asked several stoma care nurse specialists to send in some questions that they have recently been asked by their patients and felt they needed advice from a dietitian before answering their patient. I was fortunate enough to have the time with Melanie to pose a few of these questions to her, so let's hear what she has to say. As a stoma care nurse, one of the key areas that we always get asked questions about is diet. So can I ask you, Mel, please, what diet and fluids would you recommend for someone who's vegetarian or vegan, perhaps, if they're experiencing a high output?
Okay, yeah. I think you have to bear in mind, obviously, that vegan and vegetarian diets are generally much higher in fibre. And we sometimes recommend to try and manage a high output stoma that people are careful with a lot of fibre in their diet as a way as sort of reducing transit time and reducing the volume of the stoma. So it's trying to look at lower fibre options really from a vegan and vegetarian diet. So the same advice would apply that we give everybody in terms of things like vegetables. So where possible, can you peel them or avoid sort of skins, pips, maybe the cores of vegetables like things like cabbages. So try and reduce the fibre in that way. Particularly with vegans, you might need to think about their protein source and how high in fibre that is. So for example, you might encourage things like tofu. That might be better than saying lots of pulses and lentils and nuts. But again, I think the key thing is it's trying to get the right balance really, isn't it? You must ensure that a vegan or vegetarian diet is balanced, so it's got adequate amounts of all nutrients in it. And it's probably going to be a bit of trial and error in terms of how far you take the fibre restriction. You may have to compromise a bit really and still allow enough fibre in the diet to get an adequate intake.
Yeah. Would you recommend root vegetables more than sort of like green vegetables, or would it not matter?
Yeah, so I think something like a root vegetable, so carrots, for example, are quite high in soluble fibre. They're often easier to tolerate than some of your vegetables, like your sort of kale, cabbages, that sort of thing. And it's practicalities, really, isn't it, with things like tomatoes. Can you cook with tomatoes where you might use something where the sort of the skins and the pips have been removed in cooking rather than sort of a raw tomato? So it's like I've said in my talk, it's about looking at how can you modify food so you can still enjoy it, but you're trying to reduce the fibre content. But also maybe try and not be too restrictive. It might be with a high output stoma, the most important thing is actually managing it from a medication and a fluid intake point of view than being overly restrictive with sort of fibre intake.
Could I ask about any advice that you would offer to an established ileostomy who's just recently been diagnosed as a diabetic?
So obviously, the general advice for someone who's diabetic is that they should have a good intake of complex carbohydrates, fibre-rich containing carbohydrates, because that's important for glycemic control. Hopefully, if the stoma has been established for quite a long time, they have been able to reintroduce quite a lot of fibre into their diet, and they are tolerating a fair amount of fibre. And it would be important that they're not following sort of a very low fibre intake anyway. So again, it's a case of just making sure that they're taking fibre to tolerance. They might still have to do things that we would recommend in terms of sort of peeling vegetables, that sort of thing, or if they found particular foods cause them problems with their stoma function, then they might try to avoid that. But generally, we would still encourage people to include fibre-rich foods in their diet. Again, sometimes do it in a bit of a stepwise thing. So hopefully from that stage of having a newly formed stoma, right, they might be having things like white bread. They go on to sort of brown wholemeal bread, and then maybe introduce higher fibre options, sort of like granary bread, really. The other important thing for diabetes is, I suppose, looking at the overall diet in terms of long-term health. So we would still recommend things like being careful about saturated fat intake, making sure that their intake is balanced, really. So hopefully, although the advice might on paper seem a bit conflicting, you can still make sure that they are having an adequate amount of sort of fibre-rich foods in their diet.
Can I ask, how often would you recommend that patients who are experiencing a high output with their ileostomy have bloods taken?
Okay. I suppose first of all you have to think about is that high output a new high output, or is it someone that we've got an established high output stoma? Because that would vary the frequency you need to do blood tests. If you take, for example, someone that's been in hospital with a high output that's gone out into the community, we would normally suggest that they have a blood test a couple of weeks after being discharged, so maybe actually in the first sort of 1 to 2 weeks. We would always try and organise that through the GP. We would all check U's and E's, because you're wanting to look at kidney function and also look at sodium, and we would also sometimes request a magnesium level as well. It depends how easy it is to get urine samples, but we would still, where possible, get a random urine sodium done, because that's a really good sign if the patient's getting salt depleted.
Yeah. It shows earlier, doesn't it, in urinary sodium as opposed to blood sodium?
Yes, it does. So if you get a random urine sample and it's got a sodium concentration of less than 20 millimoles per litre, that's going to be indicating that the patient is salt depleted, and that can be seen sometimes prior to them having a reduction in their serum level of sodium.
Okay.
Yeah.
Okay.
For patients which they've got established high output stomas, sometimes we don't, particularly in the community, monitor their bloods that frequently, but we still have to look at other markers of how you assess dehydration. So in the same ways of looking at other clinical signs. So are they reporting a reduction in urine output? Are they having those problems with things like getting dizzy from going from sitting to standing? So looking at other markers of dehydration first, really.
Okay.
I appreciate for some community stoma nurses it's often quite difficult to get bloods checked in the community.
Yeah, I think yes, often sometimes our role is a liaison role with GPs, and sometimes they look to us to suggest how often bloods etc. should be taken. So that's interesting. It's good to know.
Yeah, and it's always useful to try and back it up with some sort of guidance, whether you're following national guidance or having something more locally. I think the difficulty sometimes is you can request a blood test from the GP, but then if it comes back abnormal, you do have to have a plan in place to what you're going to do about that in terms of, do the patient need admitting for fluids, or how is that going to be organised? So you have to consider those factors as well.
Good if there's a local process in place that they can follow. Yeah. Okay, thank you. What advice would you give with regards to salt intake for individuals with hypertension, heart disease, or even a kidney disease?
Okay. For general patients with people living with stomas, yeah, I suppose again it's a bit about that conflicting advice, isn't it? If they read a lot of the literature around managing things like heart disease, kidney disease, it often tells them to have less salt. You do need to bear in mind though that the losses from a small bowel stoma are quite significant in terms of sodium. So it is important that they do have more sodium than you would generally recommend for someone that isn't living with a stoma. What we would often do is we would still give advice to increase stoma intake. If you've got a high output, you definitely still have to think about things like oral rehydration solutions. But we would then probably have to monitor things a bit more closely. So in terms of fluid balance, are they getting any other issues with things like edema and that sort of thing? So the advice still is that they should have more salt, but sometimes it's that balance of how much.
And whether that's conflicting with their cardiologist.
Yes, that's right. And often it's a case of you have to work with that specialist team. So we actually have patients that actually are on intravenous fluid and electrolytes, but we have to liaise very closely, for example, with our renal colleagues to have that balance really in terms of sometimes we might end up giving them slightly less sodium and fluid because we've got to take into consideration things like dialysis. But it's a case of in those patient groups, they really should be under a specialist team that can monitor them.
Yeah, absolutely. Okay. Can things like the World Health Organization solution and diarrhea, etc., if someone is admitted with a high output, could things like that be given as a administered via peg feeds or peg tubes?
Yeah, really good question. So if someone is solely dependent on enteral feed, so via a PEG or maybe an NG tube, and they also have an ileostomy, the key thing you have to remember is that you are often with a PEG feed giving quite a high volume. So these patients can often be on sort of 1.5 litres, 2 litres a day. And also, generally, those feeds are not high in sodium. So the risk is actually you've got a very low sodium intake and they've still got losses from their ileostomy. So actually, it's really important that you think about their total intake of fluid and also sodium. And it's a really good idea to think about giving them some sort of oral rehydration solution. So things like diarrhea, you can actually bolus down a PEG tube, and you can use that in replacement to sort of things like normal water flushes that are given with medication. It's important to still flush that tube through afterwards because of the glucose content, but definitely you need to think about the fact that these patients need to be given more sodium, and that's a good way of doing it.
Brilliant. Okay, that's great. Thank you. Thank you for watching this episode. I do hope you've enjoyed it and it has been able to offer you further insight into the diet and fluid needs for our patients with a newly formed stoma, including those who are struggling with a high output. This episode can be viewed on demand from the Salts Healthcare website. It can also be stopped and replayed at your convenience, giving you time to write notes or reflect on certain aspects of the session. If anyone has any follow-up questions, then please do reach out to us and email discover@salts.co.uk. Please click on the link at the end of this episode or from the main Discover Series page on the Salts Healthcare website to access the evaluation form. On completion of this evaluation form, you will be redirected to a page enabling you to print out your certificate of attendance. The next episode in the Discover series will be launched on Thursday, the 7th of April. In this next session, we will be joined again by Melanie Baker, who delves even deeper into the challenging issue of maintaining adequate fluid and electrolyte support for ostomists with a high output stoma. Thanks again for watching, and we look forward to seeing you next time.